community to share with us their ideas and their innovations and hopefully bring them to a global audience. Many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have. HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur, the leader is a communicator, the leader is a manager, the leader as a negotiator, the leader as a follower, and the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty. In this episode of HLA Live, Matt Howard introduces an episode about military medicine.
So hello, welcome to tonight's episode of HLA Live. My name's Matt Howard. I'm a orthopaedic registrar currently working down in the Southwest. I'm a current HLA scholar and I spent several years as a doctor in the Army prior to starting specialty training. The theme that we're talking about tonight is military medicine. Well, that's clearly a very broad theme and we can't attempt to cover all of which that entails, but we have 2 great panellists who we're going to hear from and by exploring their stories and experience from the military, we're hopefully going to tease out some themes on leadership, the interface between military and civilian medicine, potentially how you can get involved and where the future lies in the field. So we've got with us tonight Adrian Meller, who's a surgeon commander in the Royal Navy. He's deployed in operations to Afghanistan and Iraq and is currently working as a consultant cardiothoracic anaesthetist at James Cook Hospital in Middlesbrough. He's heavily involved in research, particularly high altitude medicine, and has combined this with a passion for mountaineering to lead climbing expeditions all over the world. We've also got Matt McCarthy, who spent 20 years as both a regular and reserve soldier, deploying on multiple operational tours. On leaving the regular army, he led the sustainable development charity Rally International in Borneo in India, and he's currently studying medicine at Newcastle University. So we're going to hear a bit first from Adrian and then Matt, and then we're going to have a bit of a free-fall afterwards to discuss any topics, any other issues. That said, both of you feel free to pitch in at any point. This is all very informal. So Aid, if we come to you first, clearly you've done some fascinating and exciting things within the military, which I want to come on to in a bit. But first, if you could take us back to the origins of your military career, how you came to join up and your sort of early experience of that, if that's all right.
Yeah, sure. It's a long time ago now, but I think I identified fairly early on as a medical student that there was a bit more interest to be had with a medical career than just climbing the greasy pole of the NHS. And that was about the same time as we were given a fascinating talk about the Falklands conflict, which tells you how long ago it was, when I was a medical student. And that sort of inspired me, I think, to join the Navy, initially to do something different for 6 years. And here I am 32 years later. And I think really what's kept me in is still that sort of wanting something different. There is sometimes a conflict between having, a full-time NHS job as I have, and then a full-time military role, and trying to mix those 2 careers and stay sane as opposed to anything else. So there's lots of opportunities, lots of interest. And whilst the world has changed quite significantly, I think that is still true of the military. It throws a lot more in your direction, often when you least expect it. So yeah, and I think again with the military, I had a lot of opportunities as a trainee, which probably kept me in when I was at an earlier stage of my career. And certainly at that time, and it has changed a little bit now, but as a registrar, you could pick and choose where you went because you were free to the host trust. And so during my training, I had a lot of different opportunities to work in different regions. So I worked in the Southwest, in London at several different teaching hospitals, over in Australia, up in Sheffield. And so I was able to move around a lot. And actually that was probably at that point in time what kept me in the military, were those clinical opportunities. And then once I became a consultant and more senior, again, the benefit of the military was it gave me that sort of, I had my grounding in my military role, which was all I had to do, provided I kept myself current and appraised and all those other good things. And that enabled me to have the time and space to generate the research interests and kind of have fun, but hopefully achieve something useful at the same time.
And tell us a bit more about some of those military experiences in those early formative years. Any deployments or anything that stand out?
Well, I think, I mean, going right back to the start, you know, the military career, if an initial 6 years rather with the military would split into 3 years of the military getting what it wants from you, which is general duties stuff. So depending on the service you're in, but in the Navy, it was either ships, submarines or Royal Marines. And I spent 3 years in submarines as a sort of fresh out of house jobs then. So, you know, finished foundation years as effectively as they were then. And then 3 years single-handedly away on submarine patrols and the like, which I think was quite a key developmental point, just in terms of being comfortable decision making in quite a very, very remote environment, with, you know, as the only doctor on a submarine, obviously a low risk of anything happening, but if anything medical did happen, you were having to think on your feet and do the best you could and be comfortable with that. And then actually, as happens to military trainees generally, through my registrar time, I was reasonably well protected from deployments and the likes. I did manage to, by accident of timing, finish up on an aircraft carrier, the previous generation of aircraft carriers, obviously for 18 months, which again was fascinating times, albeit a lack of progression with my registrar training, which was again one of those conflicts of the military prerogative versus the sort of trying to keep up with my peers in the NHS stream, if you like. And then I accredited as a consultant pretty much as the invasion of Iraq kicked off. So I'd done about 2 months at my host trust, and then spent best part of 5 or 6 months away in the Gulf on an aircraft carrier. So and that has carried on. So it's, you know, pretty much for the first 10 years of my consulting career, it was quite regularly deployments to Iraq or Afghanistan, with a reasonable amount of notice in a fairly cyclical way. And then the last sort of 8 years or so, 6-8 years since Afghanistan went away, it's been back to a lot of time at high readiness, short notice deployments on, you know, ships, usually on ships, usually as an insurance policy. So you don't expect to be busy, unlike, you know, field hospitals in Iraq or Afghanistan, but you're there for what may happen, and generally with a small team, quite lean manned. So if it did kick off, there would be a lot to do.
You mentioned early on you spent some time in a submarine, which was the sole reason why I was adamant I would never join the Navy. And you said that made you, you know, comfortable going back to civilian with dealing with clinical situations and uncertainty. Moving forward as a consultant, have you found that those deployments abroad and those experiences that you've had have helped in your NHS civilian practice as well?
Yeah, absolutely. I mean, I gave when COVID was, you know, going to kick off in March sort of time, we were having to change rotas and deal with a huge amount of uncertainty at work. I mean, I did a chat sort of similar to this with my colleagues and said, look, you know, this is what will happen. We'll always be fighting with inadequate information. It'll need good followership. The rules will change every 5 minutes. We won't know whether we're coming or going, but we didn't start it. We've just got to do our best, you know, which was always my approach to stuff happening. And it, you know, in a way, it keeps you sane by detaching yourself a little bit from the emotional burden of what's happening and getting on with the clinical burden. Becoming a good follower, you know, is a very important thing. It may be a bit of a cop-out in that you don't want to take responsibility, but equally, you've got to follow, and you've just got to believe that somebody somewhere knows what they're doing. Otherwise, you know, the stress levels rise and life becomes impossible. And I think all those, there's many and varied similar parallels, but I think all those things, you know, the one thing that I always refer back to is on the submarine. The submarine is effectively in medical charge of the boat. So my role as a doctor was to advise the captain, but the captain would know whether or not the risk, and these were boats carrying nuclear missiles, so whether the nuclear deterrent program should take precedence, or whether the guy with an appendicitis that I thought had an appendicitis that I wanted to land took precedent. And it never did come to that, but if push came to shove, it would have been the captain's decision as to what happened. So again, that's the kind of followership. You could see it as abdication of responsibility or good followership. That's up to you, but that's you know, that's kind of how those things work in the military anyway.
So as well as that, the sort of deployment side of things, you've done a lot, as we said, with regards to research, high altitude stuff within the military. Tell me a bit about how that came about. Was that something you fell into, or something you had a passion for from an early stage?
Well, in fact, going back to why did I do submarine, it was an accident of mountaineering because I wanted some paid leave on them. And the quid pro quo was if I volunteered for submarines, which, as you pointed out, not many people do, then I got the paid leave to go on a climbing trip to Pakistan back in the early 90s. So it's been a sort of a habit of mine, really. The altitude medicine was serendipitous, really, in that I've been interested in altitude medicine, but the academic side of it was just a chance meeting in Afghanistan with a colleague of mine, Dave Woods, who's now Colonel Dave Woods and Professor of Military Medicine. We'd been medical students together, but our military paths hadn't crossed for 20 years. And he happened to have done an MD with Hugh Montgomery down in London with the ACE gene and the high altitude implications of that. Dave and I mean, we are very, very firm friends. He's been an inspiration and persuaded me to do an MD, oversaw my research. And the military need was that there potentially is a need to deploy troops at high altitude fairly rapidly. We don't understand high altitude illness in the broadest sense at all. So the research was towards that justifiable military aim, whilst enabling me to, you know, read more, learn more, and to some extent do more mountaineering, which was a bit of a win-win, really.
And I know you've managed to do a lot of. The last time that we met in person was halfway up a mountain in Nepal, and I know you've managed to get on a lot of those expeditions and lead a lot of them. Has that been something that's been a battle for you? Have you had to fight for that to get that time and those and that funding, or has that been something that you've found relatively easy?
I mean, again, it's as the military put a lot of effort into running adventurous training, and I could waffle on for ages about what I think the benefits of that training are to your own personal resilience and skills. To battle, again, it's that conflict between the fact that I have to be a deployable and credible consultant anaesthetist, and, you know, and so any time away from my trust, I have to compensate for, excuse me, and I have to keep those skills, and it's also has to fit into a fairly turbulent military life where things may change at short notice. So it needs a lot of juggling and a lot of skill and quite a supportive wife at home, as much as anything else. But it's by no means impossible. And again, as part of a whole package, which is developing people, bringing people along, such as yourself, on the trips to get all those benefits, doing the research, which was part of a program to meet NATO aims, and fitting in some pretty good mountaineering objectives as well. So it takes some crafting, but the actual the aims can all match up if you try hard enough.
And on those expeditions, I imagine you've had lots of challenging scenarios and situations where your leadership has had to come to the fore. Are there any specific examples that you can think of where that's been the case? I know that, for example, on the expedition we were on, there was it was a collaboration between the military and civilian aspects. I wonder whether you've found any difficulty in those two organisations rubbing along together, or anything in particular that you've found that you've had to deal with in those scenarios.
No, I think I haven't. That's either because I've been been lucky or crafty or good, depending which way you want to look at it. And I think a lot of it's about expectation management and understanding what people want out of it. The opportunity to be able to recruit people for a high altitude expedition within the military is great. And we always have a lot of willing volunteers who take part in the research, and I'm really grateful to them because that's enabled me to have a lot of fun. There are some conflicts with that compared to the civilian world, and military people's expectations might be slightly different to civilians. So working with civilian universities who have quite different ethical approval and different timescales for doing things presents challenges, but with enough prior planning and communication, I haven't fallen foul of any of those things. I mean, the bigger challenges for leadership, I think, are dealing with the personal anxiety and being very much on your own sometimes decision making, and the difference between clinical decision making and the decision making in the mountains is that actually quite often it's your life and all your mates' life on the line, as opposed to someone who's presented with a disease and you're trying to stop that disease. You're taking in the mountains, you're taking fit, healthy people and potentially putting them in harm's way. And I have certainly had the most anxiety-provoking decisions of my life to make in the mountains rather than in the operating theatre, just because of the chaos involved and the lack of clarity as to exactly which way is the right way to go.
And presumably those experiences on the mountains have helped you keep a calm head in the operating theatre. Have you found that one has helped the other? You got that mindset, or
I think
is that
so.
drawing it too far?
No, I think that is true, and there's certainly there's a lot of evidence that working or training in an outdoor environment helps teams and people work better and cope with uncertainty. So I don't think it is extrapolating that too far to say that actually if you've been through that, the outdoor environment, and you've been tested and you've come out of it the other side, then you will be better. And I think there's some interesting data for teams working in that environment and working closely as a team after a bit of outdoor training. Not so much with medical teams, but extrapolating it. I think the transferable skills are very, very definite from different activities. It doesn't have to be mountaineering, sailing, flying, hill walking, whatever. Not necessarily going into the big mountains, but those situations where you're taking your risk management, and especially your dynamic risk management, has to be much more fit for purpose and able to quickly balance and assess what's going on.
The military and warfare has sort of, throughout history always been a great driver for medical innovation and change. From the Thomas Splint to reconstructive surgery to recently in Afghanistan with the hemorrhage protocols and trauma care. Do you think without the prospect of large-scale conflict on the horizon, for various reasons, public appetite, diminishing size of the forces, do you think there's the danger that we lose that drive and that innovation from the military? And do you think that the military should be actively prioritizing their research and their design and innovation from that side of things?
What you were just saying, if you asked me in the mid-90s what I thought my military career would entail, I'd probably put most money on being made redundant because the UK didn't really need a military, and then we had 10 years of being busier than we'd ever been as individuals in Afghan and Iraq, and an awful lot of research came out of that, quite a lot of which hasn't fully been exploited yet. So I think it's just impossible to say where we're going to be, and the military had a very active role in Ebola, had a very active role in the Salisbury nerve agent poisonings, all of which will spin up research that the military is actually quite agile in being able to deliver, because it's got people who have time and aren't tied necessarily to other clinical jobs. So I think there is always an opportunity within the military for that, and I think actually the military are now exploiting that more because they recognise it. and and are contributing significantly. There's a military civilian collaboration looking at COVID seroconversion in the students at Leeds Beckett University, when that's being run by the guys there, where I'm a visiting professor, and by Colonel Woods, who I mentioned earlier. But that's the military have had a large input into that, because the parallel group for the students are new recruits to the military looking at seroconversion in that group as well. So we've got good access to subjects for that sort of study as well. Still have to go through ethics. We can't tell them what to do, even though they're in the military. But we have a reasonable captive population, most of whom are quite keen to get involved with studies like that.
I'll put my crystal ball back in its box for the for the time being. Thanks, Aid. And Mac, if we could hear a bit about the beginnings of your time in the military, what drew you to it, and what your sort of formative experiences were in those early years.
I suppose my time in the military started as a 16-year-old, well, 15 really. I wasn't very academic at school at all. I did the bare minimum to get through. I enjoyed school, and all that. It was a great time, but not academic. And I just wanted a career that I felt would offer travel. I was really into my sport, rugby and football. And coming from the northeast in Middlesbrough, I was always told that you need to get a trade too, something under your belt. So I walked down to the recruitment office as a young 15-year-old, and was basically persuaded to join the Royal Signals. And I didn't look back, and I joined as a junior soldier back in the day. And that really was an apprentice soldier. And I spent 2 years in Harrogate going through basic training and generally learning the ways of the signals and becoming a tradesman. I became what was known as a telecommunications operator telegraph, which actually one of my claim to fame is I was one of the last people in the army to be taught Morse code. So that's how old I am. I won't give it away too much yet. But spent 2 years at Harrogate, and then went to a place called Blandford and did some more further training, and then had a fantastic career for 14 years. The best thing about the Royal Signals is that communications is key to every aspect of military operations, and the colours of my corps at the time, which was green, dark blue, and air, meant communications over land, sea, and air, and that meant that we worked with every aspect of all the other armed services. So we worked with the Navy, we worked with the Air Force, and we deployed everywhere. And I was really lucky at the very start that I went to a place called 30 Signal Regiment. Their job was basically called a Spearhead Regiment. The nickname was Globetrotters, and that meant that we were able to deploy anywhere in the world within 24 hours to set up real-link communications, satellite communications. So people in my regiment were deployed to East Timor back in the day, or they're quickly deployed to Bosnia or Kosovo when that first came up to Macedonia. And I was part of that. I took part in exercises to the Caribbean, where we practiced with the Navy if there'd been a massive humanitarian disaster, such as a hurricane going through the Caribbean. To actually deploying in operations. I was in Bosnia at the time, where we'd had a long presence. And then in 1999, Kosovo became a main concern for the British government and NATO forces, and we deployed to Macedonia to set up communications to allow the British forces and American forces to allow us to go into that country and secure stop a humanitarian disaster because of the Serbs and the Albanian population, as Kosovo wanted its independence from Serbia. And it sort of continued from there. I left 30 Signal Regiment to go to Northern Ireland, really interesting time there. And then from there, I went to a sort of a more technical role where we researched specialist equipment. And then after that, it was to a training regiment where I'd spent around about this time, about 8 years in the forces. And I was teaching young people just coming in and doing their induction course or basic training. So that person who you meet who shouts at them all the time changes a civilian into a soldier, sort of gets them sort of motivated, etc. And then after that, went back to the regular field army, and that's sort of when everything got, as you say, it got really busy. We'd always been busy beforehand with sort of low-level humanitarian intervention operations. And then from 9/11 onwards, really, deploying to Afghanistan and Iraq regularly. while we're talking about medicine, I suppose the thread through all my career and all the operations I've been on is that as soldiers, we always have to be ready for the worst that happens. And so a lot of our time was spent on dealing with crisis management, but essentially what happens when someone gets, as we used to call it, zapped? Are you able to look after your mates? Are you able to give them initial treatment on the ground until someone higher or someone more trained can come in and get your mates away to treat them? And so we spent a lot of time actually training for that to happen. And I suppose the culmination of that in my career was in 2007. In the summer of 2007, I deployed on Operation Herrick, which was Afghanistan in the Helmand province. This was the summer after a parachute brigade had gone in there, 3 para had gone in there and had a really, what they call a kinetic time, it was probably the most intense war fighting that the British Army had undertook since days of Korea, even more intense than Iraq had been. And I found myself on what was called the immediate response team. We were basically the protection and the people who would help out the guys called the MERT team, which was the medical emergency response team. So it was essentially a flying ambulance. And our job was really to recover casualties that had happened in incidents around Helmand. So we were on 24 hours call. We would wait in a tent, and if troops, civilians or enemy combatants became injured, we would get warned. We would fly to that location and cover them and bring them back to Bastion, which was a really fantastic hospital, which was able to do, great things. And that's where I really started getting inspired to do medicine. I was there as a communications specialist with this team, running off the helicopter to grab casualties. But when we were flying back, we were redundant. But as there was normally multiple casualty incidents, we would find ourselves being used by the team. And it was then I started to notice that there seemed to be one central person who would be walking down the fuselage of the Chinook helicopter and just pointing out jobs to do. More compression, squeeze bags in, get a bolus of fluid into such and such, do this, do that, they need this. And that person was, normally an anaesthetist or an ED doctor, a general duties medical officer from all 3 branches of the armed services. And I was sort of inspired by them, how calm they were, how actually this doctor, this clinician was not throwing themselves into the situation. They were taking charge of the situation. We could do all the initial muscle work of CPR, etc., or putting pressure on a wound. And it was quite inspiring to see. And it probably was the most intense 7 months of my life on the IRT team. I would say that previous to that, my military career had, prepared me. The good thing about the military is from being a 16-year-old, it spends time investing in you as a person, as a leader, and it really helps you hold a mirror up to yourself and say what you can achieve. Yeah, like there is no situation, I believe, that the army you don't come to the conclusion as a young soldier, whatever rank you are, you'd never get yourself in a situation where you think that you cannot achieve that task that's been sent you, that challenge that's been sent, you've been set in. You always feel like you will achieve it. There's no hint of failure. You will find a way to do it. And so that helped me through that really intense 7 months. Running parallel to that, the Army used to have a really great program called CAPE, which is keeping the Army in the public eye. There's a massive perception in the public that in the armed forces, you just get, especially junior soldiers, you just get shouted at from breakfast to bedtime. It's all ironing and nonsense, and you're an automaton. And the armed forces, whatever branch that you're in, that's the last thing that the armed services need from its people. They want highly motivated, selflessly committed people who are able to think for themselves in really quite dangerous or challenging situations. And so I was sent on a thing called Keeping the Army in the Public Eye, and I was sent in 2005 out to Borneo with Rally International, which is a sustainable development charity, and I sort of led treks for them out in Borneo, and had a fantastic time 3 months away with all these civvies. It was genius. Really enjoyed it. And then I came back and didn't think anything of it and carried on with my career. I was, you know, as I say, I was a bit of a bullet, a bit of an army barmy person. I was going to go all the way. I was going to become an RSM. And then after that 2007 deployment to Afghanistan, I knew the army's quite good in recognising that people need downtime after they've been on intense operations. And I sometimes wish that was built into the NHS at some points too, because I see a lot of, well, I'm sure we'll talk about that later, but I see a lot of people who could do with it, just that little bit of time away from less intense sort of care. But I knew I had quite a lot of time off in 2007, and I thought, well, I've got two options. I'm going to have a lot of money because I've not been spending it in Afghanistan. I can go on a really good holiday. I can have some fantastic nights out. I can, you know, but that was, and it had been quite an intense time. So I thought, yeah, I'll volunteer to go and rally again. So I ended up going to Costa Rica, Nicaragua as a sort of deputy program manager, and led the program out there for a little bit, and had a really great time again. And it was that point in my career, I'd done 14 years at this point, where in the armed services, for not necessarily the medical side, but in other branches, you come to a halfway point where it becomes, the pension's really good. So you have to make a decision. Are you going to stay, or are you going to try something else? And I made the decision. 14 years, I'd done everything I'd wanted. I'd deployed on operations. I'd traveled the world. I'd made great friends. That I would try something different. So I rally, luckily, opportunity to lead their program in Borneo, in a place called Sabah in the north of Borneo. And yeah, I jumped at it and I didn't look back. And that was a fantastic, again, 6 years of my life. And I managed to work in all their countries of operation. So Tanzania, Nepal, India, Borneo, just an amazing time. But again, that thread of medicine, we have all these volunteers from around the world come to do our programs, and to support that, we have to have medics. So doctors, they're normally FY2s or just going into FY3 year, or just junior regis who've got a bit of time off on that transition to Australia or wherever they're going, or paramedics, nurses that will come on the program because we were working in such remote areas to keep people safe. And I'd always thought about medicine, and I'd even talked about it a couple of times, but never really felt that it's too late for me. I left school at 16. I've got some GCSEs. That's about it. It's an impossible dream. And then it was a young F3 medic who spoke to me and went, it's not about being clever. It's about, I think most people agree with this, is that there is really clever brain boxes out there in medicine. But for the most part, it's whether you're willing to work hard, and it's not about being particularly clever. If you're willing to put the application, you will make it. And I thought, yeah, I can work hard, definitely. And then Durham University at the time had a thing called widening participation. And I remember the first phone call back to Durham, back to Stockton, and inquiring, and yeah, that was it. I started the process. I had to, get ready for this UK CAT test, and my military background and being a senior NCO, I was very, very thorough all the way through it, and looked at every angle. Started teaching myself maths again. Started doing biology and stuff, ready to start foundation year at Durham, and yeah, here I am now, 6 years later in my final year. It's been really good.
What a journey. That's amazing.
Yeah.
You've spoken there really powerfully about something I feel quite strongly about, which is this, what medical schools and universities are looking for in what makes a good doctor. And I couldn't agree with you more that, having 3 A stars or whatever they go up to now at A level, and, playing grade 8 violin is of very little consequence to how you are going to act and function as a doctor. And those other harder to determine and harder to quantify skills that a military career such as yours has clearly given you stand you in extremely good stead to succeed and achieve in that career, in a medical career. it is hard though, isn't it, to quantify them and to put a label on them. Do you think there's a way around that? Do you think medical schools should be doing more to widen their participation? I know there are programs like the one you spoke about, but do you think enough is being done? And if not, what do you think the answer is?
I think it's a really good question, and again, I don't think they do enough at all. No, because that program with Durham's ended with the ending of the Durham Foundation School, so Newcastle didn't really want to continue that program. So when I was teaching young civilians to join the army, when I was at what we used to call the training regiment, we had a phrase called train in, not train out. So it was everyone who had the motivation to come to start that journey to become a soldier deserved all our efforts to. So we trained them in. We weren't trying to weed them out, if you know what I mean. They would select themselves out. We would do everything in our power to ensure that they had everything they need to succeed. And there has to be a certain standard to study medicine. Of course, there has to be a certain level of understanding. But I do feel that my admiration for 18-year-olds starting a medical course nowadays is through the roof, because their resilience to suddenly be an 18-year-old to be in a course of 400 people, of highly educated people who are very, very clever. I don't feel like there's that support there to train them in. It's more like there's no individual support there. There's that remoteness, I feel, at university. And I think if that could be removed, it could be more individual support or smaller courses. Maybe that would help. Definitely try not to get rid of people, but find out what their issue is through training, I suppose.
Ade, have you got any thoughts or views or experience on that? I appreciate we're moving slightly out of the realms of military medicine here, but it's something that I'm quite interested in.
Yeah, no, I think it is. Mac's insight is fascinating, and when I look back to when I joined as a medical student, I had no family background with medicine at all. I was, the first of my family to go into medicine, first of my family to go into the military, and in the days pre-internet and relatively difficult to get hold of information. I mean, I can remember being very much at Mac's stage and not having a clue what came next, knowing that I had to try and get a house job, and the best way to do that was probably play rugby, and then you could go and be an orthopaedic surgeon. But apart from that, I didn't really have a clue. In many ways, I knew more about the Navy because I'd seen an hour-long presentation at the Medical Society and then went and chatted to someone in the careers office. But it was all a bit of a mystery to me. I mean, I do think now, to kind of counter what Mac's saying a little bit, when I work with medical students, when we have them through James Cook for training, they're all so much better informed than I ever was. They know what they need to be doing. They'll come to us as fourth-year medical students, keen to do an audit, get a poster, get a presentation, get something on the CV, because they know they'll need that for benchmarking at FY2 and beyond. And so I know exactly what Mac means. I think it has got better, if that's any consolation. It's probably why doctors now are more human beings than going back to my generation when, a lot of people joined and weren't really human beings, and no one ever encouraged them to be, and you got fed into your silo of playing rugby and being an orthopaedic surgeon. Not having a go at you, Matt, but that was how life was. I agree with Mac, but I do think it's getting better, if I can be optimistic.
And Mac, your time at university, whilst still being in the army, how have you had pulls on conflicts on your time with regards to that, or is it been easily managed?
Well, it's been a godsend, I would say. Firstly, my time of life, start studying medicine, it's a dramatic drop in income, so to be able to support myself, so the reserves offered chance to get paid, actually, and and to be part of that family and to be networked with clinicians up and down the northeast, and who I regularly see on my placements, who are always willing to help and give me that extra time. So there hasn't been a conflict, because the reserves are really good in the fact that you've got to treat it like a 0 hours contract job. You can put in as much as you want and get out as much as you want to. And they've been fantastic. They've supported me doing studying humanitarian disaster courses over in Ireland at the UN school, and that's been got really high profile course there. Humanitarian law and the Geneva Convention courses I've been on. Yeah, it's been fantastic. And also, regular on a Tuesday, I get exposed to, so 2 Tuesdays ago, it was maintenance of an airway, which I might not get to see until I'm actually a foundation doctor, and that just gives me that little bit of an edge, I think. So it's been great.
Yeah, absolutely. And so I'm conscious that a large proportion of our audience may well be medical students. And I would just add to that so I didn't join the army during university. I joined after a foundation program, but certainly during my time at medical school, the guys who were getting sponsored through the forces had a significantly better time than the rest of us from a financial point of view, from an opportunity point of view. It's certainly something to look at. I, as I say, joined after foundation program, and I had a surgical career in mind at that point, and spoke to some of my bosses at that time and said, look, I'm thinking of this, what do you think? And a large proportion of them said, don't do it, it's madness to step off the pathway, you just need to bash through, get your training number, etc. And I nearly listened to them, and I'm very glad that I didn't. There were some who spoke sense, because from what Matt has just said, the opportunities and experiences that the military can give you can be incredible, and those transferable skills that you get, taking a couple of years out of the training pathway, pales into insignificance with what you can bring back. And that was certainly the feedback that I got when I was coming back into the NHS, applying for specialty jobs. It certainly wasn't an issue. So to anyone out there who's weighing it up from that point of view, I would say go for it. All that being said, there are definitely some downsides to military life. Ade, you touched on a couple of them earlier, but I was wondering if I could get both your opinions on what those downsides are, how you've dealt with them in your careers, and do you think that people joining up are given enough exposure to those downsides before signing on the dotted line?
I think the downside to it is the push and shove of two bosses, effectively. So secondary care, anyway, we are all out in the NHS to keep our clinical skills up, contribute to the NHS. But I spend 6 months or so of the year on between 2 and 5 days notice to go away. And of course my colleagues in my NHS job love it when I phone up and say, sorry, I've got to go away. So this year, for example, as I said, COVID was kicking off. I'd given the talk about expect the unexpected. We'd gone into a full shift system, so I'd done my first row of nights in the hospital. Was woken up after I just got to sleep first thing in the morning by a phone call saying, you've got to be in Plymouth for 5 o'clock tonight, you're sailing on RFA Argus crossing the Atlantic. Mac will know how long it takes to get from Middles to Plymouth. And I'd got 8 hours to pack my bags, get a hire car, get to Plymouth, get on a ship that was going to sail. And that probably is the downside. Now, I think a lot of that happens at the start of your career, which is kind of what you sign up for. It's all exciting, it's all glorious. It gets a little bit more tedious when you get as old as me. And although once you're away, you're better at coping with it. I have my strategies. I know what to pack. I know how to get on. But I think that is possibly the biggest advantage and the biggest drawback, depending on your view. At the start of your career, that's great opportunities for doing stuff. And even now, I think if I've been a consultant, as you were saying about getting through your training as quickly as possible, I've now been a consultant for 22 years. And I look back on the 18 months I spent on the aircraft carrier when I was incredibly fed up to the back teeth of being on the aircraft carrier. I should have enjoyed it a lot more because, 18 months now, it just paled into insignificance. I'm getting slightly off the thread, I think, aren't I? But so yes, often the advantages are disadvantages, and the other way around. And it's finding a mechanism to cope with that. Really, I think anyone who joins the military wants to do it because of the unexpected. And by definition, when that unexpected does happen, Mac and I probably met on the back of the Mert in Afghanistan in 2007. In fact, I'm sure we have. When that happened, I first went out for the first time at a few days' notice into a very active war zone, flying in the back of the helicopter. And it's very interesting. I think you develop the skills to cope with it, and it is a developed skill, as Matt was saying. The whole thing about the military is you don't do that on day one. Day one you might go to Dartmouth and be struggling a bit with ironing your sheets, cleaning the sinks or whatever you're supposed to do, which actually means by the time you've got to your 12th year in and you're suddenly in a helicopter in a war zone, you've actually got the skills to deal with it, and it is quite nice and progressive. So I don't think that answers your question at all. Sorry, I think I've rambled there.
No, it does. Matt?
What really prepares you for there is, times when you think, what am I doing here? And for me, it was normally on a course in Brecon. It's lashing down. I'm falling asleep on top of my rifle and sort of crazy frogging it in a bivvy bag because I'm freezing cold, wet. But like on certain operations, like you said, that Afghanistan tour of 2007 was pretty intense, and it felt like I was in a movie most of the time, as the Chinook was like just swinging round and I'm running off, and it's not a movie, it's happening for real, because there's been an IED gone off and there's people pretty seriously injured and they're actually calling for the moment. It's quite heart-stopping when you see that, but training kicks in, you do what you're supposed to do, and it's only when you're sort of in the tent afterwards with the lads that there's a big blowout and you start reflecting about what you've done. And I would say with everything, the best thing about the army was the team that you're in. I mean, all the thread through my training, and I'm sure that's the same down in Dartmouth and your training at Sandhurst, and what you did with battalions that you were attached to or ships that you were attached to, was that camaraderie, that team spirit. That's the very first day, was don't let your team down, don't let your mates down, don't let your oppos down. And even as I went through the ranks, it was always looking after the lads. And most of the armed forces, I feel, are not very, they're apolitical, they're not very soft and woolly and huggy, but there is this sort of Mickey take and finding the dark humour out of everything and absolutely ripping into each other. And it's a way of saying, mate, I love you, sort of thing, but really I'm just going to absolutely rip the shreds of you to bits. And it just completely can make what was a really horrible situation, just, someone can say some really dark humour and then you're all laughing. One person used to say to me, this is all type 2 fun, this, isn't it? At the time, this is incredibly, I can't swear on this, obviously, but this is incredibly rubbish. But when we look back on it, wasn't that fantastic? So I meet guys now, and we talk about these times, or stood in a Sanger in Iraq, for 8 hours at a day, sweating. What an amazing time we had. And I can't remember it being an amazing time at the time, but yeah, we laugh and we joke, and we think it's incredible. So yeah, that's how we get through it, I think.
Brilliant. I'm looking at the time, and I think that is actually a rather nice spot to end on. I hope that this hasn't been type 2 fun, and it's been more enjoyable. Unless either of you have got any passing words of wisdom that you want to espouse, then I'd just like to say thank you both. It's been extremely enlightening and entertaining. Thank you very much for your time, for agreeing to do this.
Thanks, Matt. Thanks for the opportunity.
Same. Thanks very much. Yeah, it's great to chat and bore on. So yeah, thanks a lot.
Guys.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programs? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Marlwaner, the Director of the HLA, and it's a good night from all of us.